that, but I thought it'd be more useful in the setting of being my first kind of lecture to this group to just give some general overviews of the things that us neurosurgeons do and think about when it comes to the NICU patient population. A little background on me. I've been at Chalk since the very start of 2024. So getting on almost 2 years now. Prior to that, I was at Loma Linda Children's Hospital for a little over 4 years, maybe 4.5 years. And that was my first gig out of training. I did my pediatric neurosurgery fellowship up in Toronto at Sick Kids, my neurosurgery residency training at University of Washington in Seattle. Prior to that, I was at schools out east, Harvard for medical school and Yale for undergrad, and grew up in the DC metro area because my dad was a federal judge with the U.S. Patent and Trademark Office. So that's sort of my circuitous course to Southern California, kind of bouncing to all corners of the country and a quick pit stop in Canada. And so let's sort of get into it. Let's see, why is this not advancing? There we go. All right, and you guys are seeing the slides, correct? Not presenter view.
Correct.
Wonderful, good. So I do have one disclosure, and that is I'm serving on a newly formed hydrocephalus physician advisory board by a company called ASCLAP. Um, the reason I'm on that board is because I'm very, very excited about a device that they're rolling out to the US market that's been in use in Europe, mostly the UK and Germany, for almost 10 years now. It's a wireless implantable ICP monitor that can be integrated to a shunt. So it takes the mystery out of knowing kind of what someone's pressure is at any given moment and can really reduce the burden in terms of the number of CT scans little ones get, which is good for radiation exposure and just give a higher level of confidence that shunts are working. Very excited about that. The FDA has really gummed up the works in terms of getting it approved in the US. And so I'm on a small advisory board to sort of be the initial US super users of that device when it comes online. But that's not a topic for today's discussion in the NICU patient population, so I don't think there's any relevant conflicts. All right, so we're going to cover a little bit about germinal matrix hemorrhage and post-hemorrhagic hydrocephalus, which is the leading cause of hydrocephalus in our country and in other highly developed countries that have excellent NICU care. If you were to ask what is the number one cause of hydrocephalus worldwide, including the developing world, you would certainly not have this be the cause. It would be post-infectious hydrocephalus, because in places without high-level NICU and prenatal care, um, very premature infants are likely not going to survive. And moreover, without excellent prenatal care, you will have much higher rates of perinatal infections, and that can obviously lead to post-infectious hydrocephalus. We'll touch on congenital hydrocephalus and use that as sort of a lead pad to mention an alternative way to treat hydrocephalus that's not a shunt, using an endoscopic third ventriculostomy, because that's relevant to some patients with the most common form of genetic hydrocephalus, which is called L1 CAM or X-linked hydrocephalus that causes an aqueductal stenosis problem. We'll talk about open myelomeningocele as well as closed spinal dysraphism and just briefly touch on birth trauma. Please make this interactive, slow me down, speed me up, anything that's boring. I'm happy to blast through. I've got plenty of slides and could talk endlessly about this stuff. So I think it's good to start when we do germinal matrix hemorrhage with what is the germinal matrix? Does anyone know what the germinal matrix is? Like, what does it do? Why is it there? All right, no takers on questions, I guess. So the germinal matrix is a transient structure that existed in everyone's brain that is listening to this talk or giving this talk, but it's not present in anyone's brains currently, given that we're well past the age where it existed. But basically, you can think of the germinal matrix as the nursery where the neurons that populate your cerebral cortex were born. So the neurons, you can see my mouse, are all kind of living out in that strip of gray matter out on the surface of the brain, but they didn't start their little lives as neurons out there. They started their lives as neurons deep within the brain, kind of just tucked under the lateral ventricle, and then they migrated out to the surface after they were differentiated into neurons. It's quite remarkable that they make that long trip through the brain tissue successfully ever. And certainly as a pediatric neurosurgeon that takes care of patients with medically intractable epilepsy, Neuronal migrational abnormalities or abnormalities in those neurons getting to the right place can be a cause of focal epilepsy and is one of the forms of focal epilepsy that we love as neurosurgeons because we can often outright cure the patient's seizure disorder by removing that little neuronal migrational abnormality. But that's for a different lecture. Today, the focus is just understanding that the germinal matrix is this transient structure. It begins developing very early in gestation, like right around the time the brain starts developing, around 7, 8 weeks. It gets really revved up in kind of the late teens, early 20s of gestation. And then by about 24 weeks gestational age, it starts regressing, and it's not fully done regressing until 35, 36, 37 weeks, somewhere thereabouts. Now, the body almost like seems to know that this is a transient structure. It's not like a permanent structure. And it sort of feels like when you see buildings that have temporary scaffolding put up so they can do repairs, that temporary scaffolding wouldn't stand up against a hurricane or a tornado, but it's not intended to. It's just a temporary structure. And that's kind of the way the germinal matrix is. It needs lots and lots of blood flow because it's doing a lot of work to generate new neurons. But the blood vessels supplying it, while dense and rich in terms of the amount of blood flow they provide, they're not as they're not as robust as sort of the permanent vessels that are going to be with that child for life. And so they're the most prone spot of highly vascularized tissue to bleed if there's a change in blood pressure, or the shock to the system of transitioning from fetal circulation to circulation outside the womb. And so that's why this structure that's so important for our brains to form is also the most likely spot to bleed if you're a premature infant. You probably are all familiar with us speaking about germinal matrix hemorrhages in terms of what grade is it. And so always worth just kind of touching on the grades. So a grade 1 has no blood in the ventricles. The hemorrhage is confined to that little zone right under the lateral ventricle where the germinal matrix either resides or once resided. Grade 2 is where it's sort of blown out through the germinal matrix and there's some blood in the ventricle, but it fills less than 50% of the ventricle. Grade 3 is either where the ventricles have become dilated in addition to there being blood, or there's a greater filling of the ventricles with blood. And then grade 4 is where you've got blood in ventricles and blowing out into other portions of the brain tissue. So you have extension into the brain parenchyma around the ventricles. Now, these different grades have big implications for rates of in-hospital mortality, which is in green, as well as rates of post-hemorrhagic hydrocephalus. So grade 1 hemorrhages, very, very unlikely, like 99% of them do not go on to get hydrocephalus. Similarly, grade 2s, it's a pretty small subset, 1 in 25 get it. But when you get up to the grade 3s, grade 4s, it becomes much more common. And there's some papers that would even show grade 4s having as high as like 40, 50% rates of hydrocephalus. But certainly it's the grade 3s and the grade 4s that are much, much more of our neurosurgical practice in managing the hydrocephalus. So there's lots and lots of risk factors that have been identified. This table, I think, was the nicest summary of all the risk factors with appropriate citations. You can go through this when you want, but in vitro fertilization, multiple gestations, being more premature, like very, very low birth weight or extreme prematurity. Transfer after delivery is actually an independent risk factor. So there's lots of things that are risk factors. I think my takeaway from this is many of these risk factors are out of our control, right? Like it's not in our control as the neurosurgeon that the patient arrived to this world very, very early. But there are a few that are in our control and are worth noticing, such as, the transfer after birth and not overstimulating these very premature babies, things of that nature. So when it comes to the neurosurgeon getting involved in the care of these patients, it's primarily to address the consequences of the germinal matrix hemorrhage vis-a-vis the development of hydrocephalus. And really, it's sort of two big questions that we're always asking ourselves when we're following these babies. When is the right time to intervene? And second, is this purely a communicating hydrocephalus, which is generally the case, or is there an obstructive component? And I'll break down what I mean by communicating and obstructive in a moment. For the when to intervene, whether you guys realize it or not, a lot of what the neurosurgery team is doing behind the scenes is that every single time one of the NICU babies that we're consulted on gets a head ultrasound, we are plotting 6 different measurements of the ventricular size on these sorts of charts. And on the x-axis is age in gestational weeks. On the y-axis is the size of that particular ventricle measurement. And basically, this is all grounded in data that Terry Inder, your next speaker, was very instrumental in producing, that basically showed if you intervene when ventricles reach certain size thresholds, and that's well before the patient has florid symptoms of hydrocephalus, you are going to have better neurocognitive outcomes when you follow those kids farther on in life. It seems intuitive, but believe it or not, it took the field some time to shift in that direction. If you went back, I don't know, a quarter century, the standard way to manage these kids from pediatric neurosurgeons was to observe them until they had frank symptoms of hydrocephalus, i.e., a bulging fontanelle, bradycardia, progressive macrocephaly. But if a baby has bradycardia from their hydrocephalus, it means that hydrocephalus has gotten so bad it's causing brainstem dysfunction. And one of the problems with that, or like prior treatment strategy, is that unlike an adult brain, a baby arrives to the world with very little myelin, meaning this fatty tissue that's put around the axons in the brain. That lack of myelin makes a baby brain a whole lot mushier in consistency than the adult brain. And that's particularly true in the white matter that surrounds the ventricles. And so in a baby that's under 35 weeks gestational age, dilation of the ventricles won't necessarily manifest with a big bulging fontanelle or progressive head enlargement. It might only kind of destroy the mushy white matter that's surrounding the ventricles without causing big changes in the external exam or in the early stages, evidence of bradycardia or other symptoms. And so with that in mind, if you wait until they're symptomatic, you've probably waited until they've hurt a lot of their white matter. And so that's why there is this big shift in the field that's been pretty well established, I think, for about 10, 15 years now at most major pediatric neurosurgery centers like this one, that you should be tracking them with head ultrasounds and intervening when they reach certain size thresholds. And this is just a breakdown of what you do in the green, yellow, and red zones. The next question for us neurosurgeons is, what kind of hydrocephalus are we dealing with? Is this purely communicating or is this obstructive? So what do we mean by this? So obstructive means that there's some blockage of flow somewhere within the ventricular system. So we all have 4 ventricles, 2 lateral ventricles, a third and a fourth. And there's a few narrow apertures within that system where CSF has to be able to flow through the system. There's the relatively narrow aperture here between the lateral ventricle and the third ventricle called the foramen of Monro. There's a right and a left foramen of Monro, one for each lateral ventricle to drain into the third. And then the narrowest of apertures is the cerebral aqueduct here, which connects the third to the fourth ventricle. And so if someone has either congenital aqueductal stenosis, where that channel didn't form correctly, or let's say a germinal matrix hemorrhage patient has blood clots within their ventricles and their body's immune system, in trying to kind of clean up those clots, lays down kind of the equivalent of scar tissue. We call them intraventricular adhesions. But if they lay down an intraventricular adhesion that blocks that channel, then that's also effectively a form of obstructive hydrocephalus. And so for some forms of obstructive hydrocephalus, we might be able to intervene in a way that's different from a shunt. This MRI image kind of gives an example of someone with aqueductal stenosis. And the thing that would catch a neurosurgeon's eyes is that the third ventricle is very dysmorphic and enlarged and rounded. The lateral ventricle, the same can be said. But the fourth ventricle has a totally normal shape and contour. And that's kind of the pattern you're going to see with an obstructive problem, where the ventricles upstream, so to speak, of the obstruction get rounded and dilated, but the ventricles downstream do not, because they're draining freely as they normally would. And for these patients with aqueductal stenosis, there's a strategy that can be used to treat their hydrocephalus that is not a shunt. It's an endoscopic procedure where basically you're just creating a new channel in the floor of the third ventricle so that those 3 ventricles upstream of the obstruction, the 2 lateral and the third, have a new pathway to get CSF out to the surface of the brain where it can be absorbed. And we'll touch on ETV a little bit more in a bit. The communicating form, which is the more common form we see in isolation with germinal matrix hemorrhage, is that the patient hasn't developed an obstruction within their ventricular system. Fluid can move through that system fine, and it can escape the fourth ventricle here to get out to the surface of the brain. The fourth ventricle has three channels at its outlet, one in the middle called Magendie and one on either side called Luschka. So basically, in a communicating case, everything is open. The problem lies in the fact that they're not absorbing their CSF back into their bloodstream the normal way in the subarachnoid space. And in someone with that communicating form, you're going to see a different sort of picture where all four ventricles become dilated. So unlike the last picture I showed you where the fourth ventricle had sort of a nice pointed roof, this one has kind of a rounded roof and is enlarged. So that's more of a communicating type picture. And so for most of our patients with germinal matrix hemorrhage, as I said, they have just a communicating form. There's not like a problem where portions of the ventricular system are blocked. And so our goal in managing them is to create a way to divert that CSF that's excessive to another part of the body. Now, the ultimate strategy for these patients that have lasting hydrocephalus that needs ongoing care is going to be to place what I like to call a definitive shunt, a shunt that has three components: a catheter that goes into the headspace like this, a valve that kind of regulates the pressure that's going to be maintained in the system and how much fluid pressure in the head needs to be reached for fluid to flow downstream, and then a distal catheter that goes to some other body cavity. Now, most of the time, the body cavity we place these shunts into is the peritoneal cavity. So ventriculoperitoneal shunt, taking fluid from the ventricles of the brain to the peritoneal cavity. Of course, though, as you know, as NICU nurses, lots of these premature babies don't just have hydrocephalus. They also have other problems. And one of the biggest other problems they can have is necrotizing enterocolitis. And so if a baby has kind of a war zone of a belly where they've had to have an XLAP and there's concerns for possible, perforations brewing, then placing a shunt that's got to remain in a sterile location and could be a risk for a nasty infection if it's put into a place where there's gram-negative bacteria, like a peritoneal cavity that has a perforation. Sometimes we are forced to place those shunts into different body cavities. The kind of second most commonly used body cavity, particularly in neonates, is going to be placing the shunt's distal catheter into the atrium of the heart. So it's draining the CSF directly into the bloodstream. In older children beyond the age of 6 or 12, if you really want them to have adult level complication rates. But in older kids, we do have other options. We can put in the space around the lungs into the pleural space. But in babies, the pleural space is not big enough in volume to tolerate all that CSF going in there. They would all have symptomatic CSF pleural effusions if we did that. So while that definitive shunt I just described is kind of what many of these patients are ultimately headed towards, placing that definitive shunt and the tunneling that's required to tunnel the tubing all the way from the head to the belly would be a pretty substantial risk for tissue breakdown or hardware erosion if you did it in a really tiny baby. And so neurosurgical centers have a sort of a temporizing strategy for those babies that need their hydrocephalus treated but are still too small for the definitive shunt. How small is too small? Well, different centers have different size thresholds. We use a size threshold of 2.0 kilograms here, which is the most common one that I've encountered. I know a few centers like to wait till the babies are 2.5 kilograms, but we're waiting for a baby to get to 2.0 before we do a definitive shunt. And so what do we do while the baby needs their hydrocephalus treated? Well, we tend to use this one I've circled on the right called a ventricular access device. There is another procedure that other centers use called a ventriculosubgaleal shunt. Both of these devices are effectively the same device. The only difference is with the ventricular reservoir, you have a catheter in the brain space into the fluid spaces of the brain, and it's connected to a little kind of medical grade silicone or polydimethylsiloxane kind of bubble that's under the scalp. And when that system's in place, nothing happens until someone sticks a needle into the little reservoir and draws off the CSF. The other alternative procedure, the ventriculosubgaleal shunt, same procedure, you just uncap the end of that reservoir so that fluid can flow freely from the brain space into the space under the scalp skin. The advantage of the ventriculosubgaleal shunt, the one we don't use, is that it generally doesn't require ongoing tapping because the scalp skin is capable of reabsorbing some of that fluid, And in many cases, the rate of reabsorption is about the same as the rate of production, such that you just have this big bubble on the kid's head for the period of time while they're waiting on their shunt. And once the definitive shunt goes in, the scalp skin comes back down and scars back down into place. Now, there's pros and cons to these two alternative procedures. The ventriculo-subgaleal shunt procedure obviously gives you less control over the amount of CSF being drawn off. And so those kids have slightly higher rates of over drainage issues where they drain too much. Ventricular access devices, while you have great control over how much CSF is being let off, because it only comes off when you stick a needle in to let it off, you are inherently sticking a needle through the scalp skin generally daily until they're ready for their shunt. And so all those needle pokes, while each individual needle poke is a very small risk of introducing skin bacteria and causing infection, the risk kind of adds up. And so if you look at the literature on this, ventricular access devices seem to have slightly higher rates of infection complications. Ventriculo-subgaleal shunts have slightly higher rates of overdrainage complications. Big review articles that have attempted to sort of come to the answer as to which one is better have generally concluded that the pros of one outweigh, like the pros and cons of the two are pretty much neutral. So if you were to go to a different pediatric medical center, you might encounter that their neurosurgical group does ventriculo-subgaleal shunts, and it's not something to be terrified of. It truly is a reasonable alternative procedure. But here we all use ventricular access devices. One of the reasons I mentioned this alternative procedure, though, is that it's possible sometimes that even though we intended the device to function as a ventricular access device, if a little bit of the CSF finds a way to kind of work its way out around where the catheter enters the dura and creates a bit of a pseudomeningocele, this isn't something that we kind of view as some horrible, scary complication in this patient population. Like, truthfully, it just is like that patient ended up getting a ventriculo-subgaleal shunt rather than a ventricular access device. So I know I can recall one patient, I think it was Dr. Yingo Khan's patient, that developed a bit of a pseudomeningocele and ended up not needing taps with the same frequency because that pseudomeningocele was sort of allowing the CSF to be reabsorbed. So it's worth noting that this is one weird situation where what would otherwise be a complication having a pseudomeningocele is actually viewed as, well, it kind of still works that way too. Does that make sense so far? Okay, I'll keep chugging.
Thank you.
All right. And then, a neuroendoscope could be a real value if there is I should have said obstructive component there instead of communicating. I was putting these slides together late last night. But some dermal matrix hemorrhage patients will have a combination of communicating where like kind of all the ventricles are enlarged, but then also have an obstructive component where one portion of the ventricular system is even more enlarged, even more dilated. And that can be, as I said, because they form these reactive intraventricular adhesions. So in these patients, it might be really valuable to do a combination of an endoscopic procedure as well as placing a ventricular access device. Basically, the goal of the endoscopic procedure would be to create fenestrations or connection channels between all the portions of the ventricular system. You're really just trying to target the portion that you think is trapped and not draining and get it opened up into some other portion of the ventricular system. That way, if you place a single ventricular access device and then use it to draw off CSF, you're effectively drawing off CSF kind of equally from all parts of the system. If you didn't use an endoscope, the only way you would be able to manage someone that's got like a trapped portion of the ventricular system appropriately, such that trapped portion is not causing injury to the brain tissue around it, would be actually to place two ventricular access devices, one into the trapped portion and one covering the rest. But the sort of data on infection complications and other things is very clear that more devices in a baby's head is not optimal. So to the extent that we can keep it simple and have a single access device, we try to do that. So if you ever see that one of your patients has come back and there was like an endoscopic septostomy performed plus ventricular access device placement, what you can infer from that is that one of the two lateral ventricles clearly looked more dilated, and there was concern on imaging that it wasn't communicating with the rest of the system. So we went through the septum pellucidum, this kind of band of connection tissue between the two ventricles, to create a channel or an os to ensure that both sides will be equal in pressure so that with our single ventricular access device, we're not only treating a portion of the ventricular system, but the whole thing. And while we're thinking about endoscopes, it's worth just noting that within the field of pediatric neurosurgery and neonatal neuroneonatology, if you will, there is an increased interest in doing what's called endoscopic lavage for this patient population, basically sticking an endoscope in primarily for the purpose of irrigating out the blood products from the ventricles. And a number of centers have been doing this to the point where this review article included, I think, a total of 8 different studies that had looked at doing this procedure on NICU population babies. Some are just single patient case reports. Others are, more robust series with as big as 83 procedures. The study quality so far for most of these, as you see, is low to moderate. There have been reports in some studies that I'll highlight in a moment of like higher than you'd expect rates of infection. I would say my stance on this at present is that it makes perfect intuitive sense to lavage out some of that blood product. I'm just not convinced that the data suggests that the benefit over not lavaging it is so great that we've kind of made that part of our routine practice. However, we're kind of doing intraventricular lavage anytime we stick an endoscope into a baby's brain. So in a way, we're already doing it for those babies that we use the endoscope for. This diagram shows the cross-sectional views of the different endoscopes. For what it's worth, my preferred endoscope is the smallest of the multi-channel ones that gives you all the working instruments you'd want. This little Lada, that's the go-to I use all the time when I'm doing procedures on babies from the NICU. This is an example of a particular study looking at neuroendoscopic lavage. They looked at 44 patients that underwent this procedure at 35 and 4 weeks on average. And it strikes me that, having more than 10% CSF leak is, certainly higher than we have with our standard treatment. And they had one rebleed that has to be at least partially attributed to the fact that they were doing some aggressive lavage in the ventricles. Now, they do conclude that if they do an analysis looking at which patients didn't end up needing a definitive shunt, they found that the patients that received the neuroendoscopic lavage at an earlier age had a statistically significant reduction in their likelihood of needing a shunt. So it's sort of like, it does look like it would offer some benefit, but it does seem to be fraught with more complications. So I don't know. It's something I'm following really closely. At this point is not part of our standard practice to do early endoscopic lavage, and that's true of most centers. But it's something that may come down the pike if the data over time becomes more favorable. Now EVDs, I think it's worth just mentioning because these are a big source of strife and stress. Thankfully, I can't think of an EVD. I certainly haven't placed an EVD in a NICU baby in recent memory, certainly not here at Chalk. It's rare that we would place an EVD in a NICU baby, but there are instances where it might be a good idea. If a baby develops a bad meningitis, ventriculitis, and infection in their brain such that it wouldn't make sense to place an internalized implant that could, retain that infection and be a nidus for the infection coming back, like an Ommaya or a ventricular access device or a shunt, then placing an EVD, a temporary drain that allows you to drain off fluid, can sometimes be your best bet. EVDs are nice because they allow you to monitor the intracranial pressure. It's not just a device that lets fluid drain. It also can be hooked up to a pressure transducer so you can keep an eye on the baby's pressure. It allows for really easy CSF sampling. So if you are putting it in for infection, which is about the only reason we put it in the NICU, the ID docs love it because they can get samples whenever they want without any stress for the baby. And then allows us to sort of effectively set what is the maximum intracranial pressure by way of how high we set that collection chamber that collects the CSF. We use EVDs all the darn time as neurosurgeons. Outside the NICU, it's really common to place an EVD for a newly diagnosed brain tumor that's got obstructive hydrocephalus from that. In the adult population, it's sort of standard of care to get an EVD in a patient that presents with a ruptured aneurysm. So there's lots and lots of use of EVDs in the land of neurosurgery. They're just not that common in the NICU. The reason they're not that common in the NICU has to do with the mechanics of the baby brain a little bit. So how these things work is really simple. I always stress to nurses that seem stressed by them because they haven't encountered them much that it really isn't something you should be overthinking too much. Really, the starting point to making sense of it is that fluid only flows downhill. It never flows uphill. In this case, uphill and downhill is really high pressure to low pressure, right? In the same way that fluid would only roll down a hill and never spontaneously roll up a hill, fluid would only spontaneously go from a zone of relatively higher pressure to a zone of relatively lower pressure, never in the reverse. And so if we think of intracranial pressure, the pressure inside the baby's head as like one height or pressure, and then we think of how high we put that collection chamber relative to the head as the second height or pressure, fluid is only going to flow into that collection chamber when the pressure in the head is in excess of the height of that collection chamber. And so let's say we set the collection chamber to 5 centimeters of water, meaning it's set 5 centimeters above the patient's external auditory meatus, above their ear hole. If their ICP is greater than 5, fluid's going to flow up that little 5 centimeter hill and down into the collection chamber. If their ICP equals 5, fluid's going to make it all the way almost to the top of the hill. It'll be sitting right at the top of the hill, but there won't be any meaningful flow. And if their ICP is less than 5, then the fluid won't make it up that little hill to get into the collection chamber. So if their ICP was 3, then the fluid would make it 3 centimeters of the way up, but it wouldn't quite make it that last 2 centimeters to get over the hump and into the collection chamber. So it's really simple in terms of mechanics. But the reason it's so scary in the NICU population is that neonatal, a premature baby's kind of normal resting ICP. Does anyone kind of know what a typical ICP is for a baby in the NICU? Not someone with hydrocephalus, just a healthy, normal baby.
-10? Just guessing.
Yeah, yeah, single digits. Let's say like, 0 to 5 would be considered pretty typical. But yeah, not high for sure. And so what's the resting pressure in an adult head? 10 to 15 would be more typical. So if you have an adult patient and you want their EBD to maintain roughly typical pressures for someone that age, you might set it to 10 or 15 centimeters of water. But if you want an EBD in a baby that's in the NICU to maintain typical pressures for age, you're going to have to set it lower, more like 5 centimeters of water. And so when you've got the adult patient set at 15 and then they wiggle down in bed a little bit, now they're set at 10, no big deal. No one's going to overdrain at setting 10. But if you've got the NICU baby set at 5 and now they reposition or wiggle in some way and get down to 0, they might start overdraining. And overdrainage is both kind of, you have a narrower sweet spot to that where overdrainage can happen if the baby kind of wiggles out of that set height. But the other scary thing is, for the same reason we were mentioning that a baby's brain is not yet very well myelinated and it's a lot mushier, if you let gushes of CSF come out without in a controlled fashion, a baby brain is going to collapse inward on itself more quickly than an adult brain will, and they're going to be prone to developing bleeds on the surface of their brain called subdural hematomas, because there's little veins that bridge from the brain surface to the inside of the skull. And if the brain collapses inward because you just drained off all the CSF from the ventricles, those veins get put on stretch and can then tear and bleed. So anyway, the reason we don't like using EVDs in the NICU is mostly that it's just a distinct patient population that needs them set at a lower pressure setting to achieve physiologic pressures. And that gives the nurses and the staff kind of less wiggle room to be out of the sweet spot. And the nature of the baby brain is such that if you do get out of the sweet spot, the consequences can be greater. So I hope we don't see a lot of EVDs in the NICU, but it is something to just have an awareness of the basic concepts. There is this kind of newer EVD, if you will, that allows for lavage of the ventricular system. It's called the IRAFlow system. We've used it sparingly in CHOC in older patients, but we have not yet used it in our NICU population. Dr. Bill Loudon, who was previously with our group, is very, very interested in trying to adapt this technology to the germinal matrix hemorrhage patient population, and it makes perfect intuitive sense. Like if a one-time lavage with an endoscope could be at all helpful, and the data certainly suggests it seems to be helpful, but a little bit complication prone, then certainly a more continuous lavage of the ventricular system makes perfect sense, because the blood in the ventricles kind of clots up, and it doesn't kind of dissolve like an Alka-Seltzer. It kind of breaks off in chunks. And so at the moment that you're able to do an endoscopic lavage on one occasion, you may clear out some of it, but there may be some solid clotted blood that you're not breaking up. If you had one of these catheters, doing lavage in a continuous fashion for many days or a couple of weeks, you would certainly break up that clot to a greater degree. The concern that myself and Terry Inder have with the current version of this device is that the catheter, because it's designed to be a dual lumen, it has a lumen for pumping in irrigation and a lumen for draining. It's just a lot stiffer than the typical catheters we stick into human brains. And that stiffness hasn't been a problem in older kids and adults that have more, firm myelinated brains. But we're kind of concerned that in the mushier neonate brain, that stiffness could pose some problems. So I'm a little bit nervous about it. I love it in theory. I was just talking to Bill Loudon this morning, who's been really involved with this company, and he kind of told me off the record, I guess it's now on the record, that the company is working on developing a more malleable model that's sort of more designed for the pediatric population. And I would certainly be on board with trying to write up a proper IRB to get that rolling at Chalk if we had a slightly more malleable version of this. I think it holds great promise. I think there may have been some chats. Let me just make sure I'm not missing questions as they come up here. Are there using this device in other hospital NICUs for the IRAFlow? Is that what yeah. Yeah. So, yes and no. Not using it anywhere I'm aware of as a routine for typical germinal matrix hemorrhage patients. I'm on an email thread with a wonderful pediatric neurosurgeon named Grace Lai, who's really at the forefront of trying to bring this technology to pediatric patients, but even she has only used it in cases of infection or older kids with interventricular hemorrhage. One of the impediments to using it in the NICU population that Dr. Loudon has actually worked with the company to try to solve is that not only is the catheter stiffer, but they didn't develop it with like a right angle connector that would let you kind of take it in through a back of the head approach. And if you took it in through a frontal approach in a baby, the size of their ventricles, even when they're a little bit hydrocephalic, is still so small that all of those holes at the end of the catheter might not be fully contained within the ventricles. And if some of those holes that are flushing in irrigation are flushing irrigation into the brain tissue itself, it could cause brain injury. And so there is a need for the adapter that Dr. Loudon worked on with the company to be approved so that you can actually have a way of putting it in the longer axis of the ventricles. But even if that were approved, to be honest, I still have some slight reservations about the stiffness of the current design. So I would be very eager to see the company produce a more malleable version of that catheter that's going to have less potential problems for the babies. And if we do end up using this with any routine in the NICU, you will have, as a nursing population, a whole lot of work with the company doing in-services to walk you through precisely how this kind of device works to regulate and pump in fluid via an irrigation bag. We definitely had that training upstairs in the PICU with our PICU nurses, and so far we've had really good results with the device. Like it's done its intended purpose of clearing out clots within ventricles and clearing infection quicker than we would typically see with a typical EVD. So I'm excited about it, but just being cautious at this point, given the nature of the current technology, as far as adapting it to the neonatal ICU population. Let's see, this is not advancing. Oh, there we go. And then, in addition to acquired forms of hydrocephalus, like having a germinal matrix hemorrhage and then developing post-hemorrhagic hydrocephalus, there are congenital forms that are either genetic in nature or we haven't figured out the genetics underlying why this baby was born with hydrocephalus. And so it represents about 10% of the hydrocephalus cases in the pediatric population, but probably greater than 10% in the NICU population at large, because many of these other forms don't arise until later in life. And for those patients with the most common form of genetic hydrocephalus, that aqueductal stenosis, as I mentioned earlier, the endoscopic third ventriculostomy is a really a nice alternative to a shunt. The thing to understand when we recommend or discuss an ETV with a patient's family is that there is a pretty well validated ETV success score that can guide us as to what is the probability that this procedure is going to definitively treat this patient's hydrocephalus. Now, in our NICU population, none of them are getting any points for their age. They're all less than 1 month of age corrected. But for those patients that have aqueductal stenosis, they get 30 points for that. And for those patients that haven't had a shunt in place, which is most NICU patients, they get 10 points for that. And so that would mean your aqueductal stenosis kid in the NICU that's just born has a 40% likelihood of this procedure definitively treating their hydrocephalus. You might think, oh, and this is just demonstrating that this has been validated. Like numerous prospective studies have compared the ETV success scores and the actual outcomes of the patients. It's been really well validated. It was actually, the success score was developed in the early 2010s by one of my mentors, Abaya Kulkarni, who's one of the hydrocephalus gurus up in Toronto at Sick Kids. So you might think, well, gosh, like 40% likelihood of success. Why in the world would anyone choose that? Like a shunt is surely higher likelihood of treating the hydrocephalus. And you're right, like a shunt has like a 99% likelihood of addressing the hydrocephalus in the immediate term. But shunts are very failure prone. Like one of the reasons I do a lot of research in shunts is because it bothers me greatly that as a shunt super user, which is true of any pediatric neurosurgeon, I'm also a super user of the most failure prone life sustaining device in modern medicine. Like no FDA would ever approve a pacemaker that has the failure rates that CSF shunts do. So the current failure rate, if you look at the biggest centers in the country, for babies that got a shunt very early in life is about 40% at 2 years. Meaning if I place 5 shunts in 5 babies today, statistically 2 of those babies are going to need another operation to fix some clogged component of their shunt by their second birthday. That's pretty high rate. And it's not like the failures stop happening thereafter. The failures continue happening. They get less, the rates of failure go down a bit with age. In the adult population, it's more like 20% rate of failure at 10 years. So same example, but in adults, I placed 5 shunts in 5 different adults today. One of them needs another operation in the next decade. But it's never like you escape that fear of a shunt malfunction. These are families that anytime their child gets a bad headache, they're asking themselves, do we need to spend our night in the ER tonight to get this worked up as a shunt malfunction? And certainly that's why I'm so excited about the wireless implantable ICP monitor to improve quality of life for both my patients and their families, frankly. But if I place a shunt, it's like a sure bet that's going to work, but it's also kind of a sure bet that at some point that child's probably going to need another surgery. In fact, at some point, they're probably going to need multiple additional surgeries. Whereas with the ETV, if my patient is doing well with that procedure a year out from the surgery, the likelihood they ever need another surgery for hydrocephalus management again in their life is under 1%. So if it were my body, I would honestly want the ETV to be tried if I had a 30% success rate, because that's a 1/3 chance that I'm spared a life with a shunt and all the stress that comes with it. But certainly I really do promote it to families when it's like a 40% likelihood of success. And certainly when I have the rare teenage patient that presents with aqueductal stenosis and has the highest possible 90% ETV success score, I think it would be crazy not to do that or to do a shunt over doing the ETV, just because the long-term prognosis for that child is so much better in terms of less medical care, less surgeries, less stress with the ETV option. So if you're curious what an ETV looks like, I can show you a little video. Warning that it's an operative video, but it's not bloody or gory. At least I think it's beautiful. But in any event, this is a video of what we see inside the ventricles. And so ETVs are super satisfying because you kind of get to see cool anatomy within like the first 10 minutes of the procedure. It's just a little skin incision, a little burr hole, and now we've driven the endoscope into the ventricular system. Let's just back up a second here. So when we first enter, we're in the lateral ventricle. Now we're passing through foramen and Monroe. So now we're within the third ventricle. Those two kind of white things there are called mammillary bodies. You have to remember that anatomists were also men and thought those looked like breasts. So that's why they're called mammillary bodies. The white band in front of my endoscope, that's the optic chiasm where the two eyeball nerves crisscross, but you're seeing it from within the ventricle. So you're sort of seeing it through. And then this little thing called a Bugby wire is being used to kind of gently try to create a hole in this floor of the third ventricle. This portion of the third ventricle that we're making a hole in is technically called the tuber cinerarium. If you look closely, you'll see that there's something down there pulsating underneath this little veil of third ventricular tissue, and that pulsation is the basilar artery. And if you look kind of where we're poking, there's also sort of like a kind of a whiteness down there deep to where we're poking, and that's the dura running on the back surface of the clival bone. That's the clival dura. And so basically, we're trying to create a little hole that allows the third ventricle to release its CSF, not the normal way through the aqueduct that's occluded, but rather to release it down into the subarachnoid spaces via the prepontine cistern, the little CSF space that exists right below this floor of the third ventricle. So once we've made the hole, we use this specialized balloon called a Neuro balloon that kind of dilates in the shape of an hourglass to then dilate that hole. We then take it down and take a look down there. Sometimes we'll find, as we did here, that there's like a second membrane known as the membrane of Lilliquist that we then have to pop through and dilate as well. Here I've sort of made a sufficient hole in the floor of the third ventricle, but I think I haven't seen this video in a long time. I'm probably going to stick that balloon in and dilate that hole again for the, yeah, exactly. Like that's a little bit of a narrow aperture for my liking in the membrane of Lilliquist. So now I'm sort of isolating the membrane of Lilliquist and dilating that a little farther to ensure I've got a really nice big channel. And then the neurosurgeon kind of knows they've accomplished the goal in this procedure when you can see what we call the naked basilar artery. Like when you can see that basilar artery with no veils of tissue covering it, you know you've done the deed. So if you look in there, there's your naked basilar, and you can see all those little bands of arachnoid. People often wonder why it's called arachnoid. Well, it's from the same root as like arachnophobia because they look like spider webs to early anatomists. See the spider webs? So that's why it's arachnoid membranes because it looks like spider webs. But that's an ETB, and this is real time. I'm not like really speeding this video up. So like from the time we're in the ventricle to the time we're like, okay, we've done the deed can be as quick as like 10 minutes, and it can be a really life-changing procedure for someone. One of my favorite surgeries we do because it's quick, it's satisfying, and it really can be remarkable what it does for someone's life. And avoiding a shunt, I can't tell you what a big deal that is.
Dr. Hanak, I have a quick question.
Yeah.
Just as you're talking and showing it, awesome. That was a great video. Nice to actually see what that looked like. Basilar artery is like a very vital, important structure, and I'm just wondering,
We try
are
not
there
to break it.
surgical complications with ETVs versus shunts? I just look at shunt as being not near as much hmm, high valuable items, and so I just was wondering if there's a difference between the actual procedure risks for the two procedures.
Yeah, I think shunts are higher risk.
Okay.
I've never seen a basilar artery get hurt. It's a theoretical risk for sure. That's why we would ask for an MRI prior to performing an ETV to make sure that there is a space in the prepontine cistern. Like if someone had, say, a big um, posterior fossa cyst, like a Dandy Walker variant, or a huge megacisterna magna that was pushing the cerebellum and brainstem forward, such that there was like a non-existent prepontine cistern. Any reasonable neurosurgeon would say, you know what, this is just an unnecessarily high risk ETB. Maybe we should go the route of shunt here. But it's very, very rare that the anatomy won't allow for an ETB to be possible. And yeah, while it's certainly a theoretical worry, there's lots of neurosurgical tricks for avoiding poking the basilar. Like one trick is that you consciously poke that initial stylet towards the clival dura so that you're poking the clivus, which doesn't mind being poked. It's a bone, it's fine. And so you poke at the bone and create this hole that's kind of cheating anterior and then dilate because the dilation is not really a worry for hurting the artery. But yeah, it stressed me out too. as someone that had never done it. But then you do a couple hundred of them and you realize it's actually fine. And I had the same question you did. I asked every neurosurgeon that had a high volume with it when I was early in my training, have you ever seen a basilar artery get hurt? Because it seems very scary. No one had ever seen it. If you look in the literature, it's exceedingly rare. And I think the rare cases that it's happened, it's been in inexperienced hands or in people that have been cowboyish and trying to do the procedure in patients that probably ought not to have been good candidates. Shunts are more fraught than I think non-shunt surgeons realize. I mean, the national average rate of shunt infections is 5%. And a shunt infection is a big to do. While no, almost I've never seen anyone get, die from a shunt infection or even come close to it. They are a royal pain in the tuchus because if your shunt is contaminated, you have to take all of that hardware out to clear the infection. Once you take all that hardware out, it's not like your patient's hydrocephalus magically goes away. So then you got to put an EVD in them to manage their hydrocephalus while they're waiting to get a new shunt. Typically, that's a 2-week ICU stay, checking their CSF daily to validate that their CSF is clear of infection and waiting on ID to finally give the blessing to let us put a shunt back in. So while it's not life threatening, it's like a 2+ week hospital stay with 2 trips to the OR, one to remove the shunt and place an EVD, one to remove the EVD and place a new shunt. Now, I am pleased to say, and I'm really proud of this fact, I'm the site director for the Hydrocephalus Clinical Research Network Consortium. And CHOC is one of 35 tertiary care children's hospitals in North America that are part of this. And CHOC and Stanford are always neck and neck for the lowest shunt infection rate of that 35 hospital consortium. So much so that I always get email from the site like, are you guys hiding your infections? Like, no, I swear we're reporting all of our data. But in any event, like we are in a good place for that. But yeah, shunt infection rates are 5% nationally. There's a small but real risk of doing horrible damage to the neck blood vessels as you tunnel the shunt, causing a pneumothorax as you tunnel the shunt, causing a bowel perforation as you place the shunt. Shunts are more fraught than you might realize, I think is the message there. But yes, I think in terms of overall procedural risk, there's certainly a lot more things I have to talk about when I'm doing a shunt consent than I'm doing an ETV consent.
Awesome. Thank you for
The biggest
covering
thing
that.
in
Appreciate
ETV
it.
consent is the family has to really grasp that there is an ETV success score. No one is going into this procedure with 100% expected success rate. And so the biggest risk of the ETV is that we have to ultimately do a shunt in spite of having done this procedure. That's the biggest risk of the ETV. Wow, shunt stuff took longer than I thought. So we can do spina bifida, review definitions. Let's blast through definitions and just go straight to the one that we all talk about, which is the open myelomeningocele, which would look like this on a baby's back, where you've got the unfolded spinal cord, which we call a neural placode when it's unfolded like this, right at the skin surface. You have this kind of veil of arachnoid membrane and then ultimately dura that's dysplastic, kind of wrapping around, kind of open, having not formed a sac. And these babies, as you know, need care in a timely fashion. They need to have their neural placode protected and kept moist. They need to be started on broad spectrum antibiotic coverage with ampicillin and gentamicin to prevent meningitis because they don't have the benefit of a skin barrier to prevent meningitis. And they need to have their back closed up in a timely fashion. The literature would say it's like you have to do it within 48 hours, but most of us neurosurgeons really want to get it done within 24. And in terms of spina bifida epidemiology, I think this is kind of interesting stuff, but it's about 1,600 pregnancies annually in the US. Obviously, it causes spinal cord dysfunction distal to the level of the spina bifida defect. So how high or low in the back that area of incomplete spinal cord folding happened has big implications for what that patient's function is going to be in terms of the lower extremities. The majority of these patients, 95+%, have associated Chiari-2 malformation, and the vast majority, 85%, have hydrocephalus requiring some form of treatment, generally a VP shunt. Now, it is worth noting that if you close these babies' backs in utero, typically that surgery is performed around 22 to 26 weeks gestation, you can have the rate of hydrocephalus from about 85% to 42%, and you can improve their spinal cord function about 1 to 1.5 spine levels over what it would have been if you didn't close them in utero. Anyone have a guess as to why closing them in utero would make their spinal cord work better?
decrease exposure to the amniotic fluid?
Yeah, absolutely. Yeah. So in a similar vein to like why a kid with gastroschisis diagnosed in utero would be delivered a bit earlier, it's because the amniotic fluid gets progressively more acidic throughout pregnancy, and that's quite neurotoxic. In the case of a gastroschisis kid, it causes the exposed abdominal contents to turn into one nasty scar ball that the general surgeons would really struggle to get back in there. But yes, it's the very acidic nature of amniotic fluid late in pregnancy that's a big problem. The other thing is just mechanical injury, right? There's no bones or skin or muscle protecting that kind of squishy, fragile nervous system tissue. And a baby in late stage gestation is kind of wedged into the uterus, especially if there's like uterine fibroids or irregularities that could put focal pressure on things. So we think that basically closing them in utero is preserving the function that could have existed from that neural plateau and not letting that spinal cord tissue be damaged through both mechanical and chemical factors. And so I'm hopeful that we can start performing these fetal surgeries here at Chalk once our fetal center opens. Myself and Dr. Yingo Khan had a lot of experience with that in our training, myself at Sick Kids and Yingo Khan at both Vanderbilt and Utah. And so we could get going on this as soon as we had a fetal program up and running. It's a really cool procedure. I think we'll just touch on spina bifida epidemiology because it's a topic that's near and dear to my heart. But it was 1992 that the official recommendation came out for the amount of folic acid you should take daily if you're of childbearing age to reduce the risk of neural tube defects. 1998 was a big year because that's when the FDA mandated fortification of enriched cereal products with folic acid. So whenever you buy flour that says enriched on it, it's enriched with stuff to prevent you from having a child with spina bifida. It's the folic acid that it's enriched with. Immediately after the mandatory fortification, we saw a decrease, and the fortification was estimated to avert approximately 1,000 cases annually. And so this chart is, I think, a really cool one. So you have the pre-fortification era, you have the optional fortification period between like 96 and a half and 98, and then the mandated, and you see sort of steady drops with those fortifications. But one thing is notable, and I think especially important to mention given the patient population we serve, and that is that the dashed line for the Hispanic population consistently remains higher than the white non-Hispanic and black non-Hispanic. So why is that? Well, there's a couple reasons. One is partially diet, and I think this is on us as a country. But we have not mandated that masa corn flour be fortified. And so if masa corn flour is your staple carbohydrate, you are not having folic acid sort of baked into your diet the same way that someone eating wheat-based products as their staple carbohydrate does. As of 2016, they've approved putting it in masa corn flour, but not mandated the way they have for wheat flour. The other is genetic. So there is a gene called methylenyl tetrahydrofolate reductase that there are some pretty common polymorphisms or variations in that gene that exist within the human population. And if you have one particular polymorphism, it's not that you're completely incapable of metabolizing folic acid, but you need a lot higher dose to achieve the sort of normal amount you need in your system. That polymorphism that makes it such that you need higher doses to avoid spina bifida has pretty wide variation among different ethnic groups. It's seen the lowest rate in African Americans, 11%. Caucasians, it's about a third of us. But in the Hispanic population and the Ashkenazi Jewish population, it's close to 50%. And so you've got both a higher likelihood that a Hispanic patient needs a bigger dose and a higher likelihood that their kind of natural diet wouldn't include folic acid fortification. That means they've kind of got the two risk factors. So I'm a big advocate for fortifying masa corn flour. If you did, some epidemiologic studies would suggest you would spare about 60 Hispanic families from having a child with spina bifida in our country each year. So if anyone wants to do advocacy work with me on that, I'm all for it. So, I guess just to touch on it, it's not just the open myelomeningocele that we deal with. We always also deal with closed spinal dysraphism. So if a baby had this kind of squishy, fatty thing on their back, what do you think that would be? They get an MRI and it looks like this. It's a lipomyelomeningocele. This next one is a baby that has a normal looking back, but they had an imperforate anus and some tracheoesophageal fistula concerns. And so the NICU said, yeah, they look like they have maybe bacterial spectrum. Let's get a spine ultrasound. And it showed a low conus. This is what their MRI looks like. And what we saw in the OR, that's what we call a fatty phylum, technically a phylum terminale fibrolipoma. Does anyone understand why fatty stuff can be kind of integrated with the spine or with the phylum? It basically is a really early stage of embryology thing where the cells in your body, but back when you still don't look like a human, you look like a ball of cells. The cells that are destined to become your fat cells have to part ways from the cells destined to become your nervous system. And if that parting of ways doesn't happen completely and some of the fat cells are left behind, you can have these unusual kind of fatty tissue abnormalities. And the reason these are a concern isn't that they're leaking CSF and that they're going to need, they're going to get meningitis. The concern is that as they grow taller, their spinal cord is tethered down low in the spinal canal and is going to be pulled on tension and create this whole panoply of symptoms that we collectively call tethered cord syndrome, where they get progressive pain in their back, progressive pain in their legs, progressive weakness in their legs, bowel bladder dysfunction up to and including incontinence, and even develop scoliosis at a young age. And so for these kids, when we diagnose them in the NICU, they're getting their definitive surgery to address their congenital spine abnormality, typically deferred until they're a little bit older because they almost never run into tethered cord symptoms in the first year of life. And so if you time their surgery shortly after their 6-month birthday, it's a nice sweet spot. It's well before they're going to have symptoms from it, but it's also after they've exited that first 6-month period of life where you have a higher risk of perioperative complications related to anesthesia. So you kind of let their anesthesia risk fall off and then act before they run into symptoms from this. So a lot of times, we'll diagnose the problem in the NICU and then see them in clinic a few times in preparing the families for bigger surgery around 6 months of life. Anyway, I could talk endlessly. I got to give the floor to Emily. I'm sorry I went a little bit over already.
Thank you
No
so
worries.
much.
That was fantastic.
Yeah, I could talk endlessly about this stuff. I love teaching. So we definitely missed some dysraphism stuff, some birth trauma stuff, but yeah, you got a good flavor of what the neurosurgeons are doing. If I could just do final thoughts, I'm sorry. So while the NICU population represents a small slice of our patients, it is a big part of our clinic follow-up. Like a lot of times we follow these children all the way to adulthood. So they're near and dear to our heart. One tiny thing I wanted to mention to this group is that I've noticed there is a perception, or maybe it's just the language used among NICU nurses, that neurosurgery and neurology are one team, but we're very, very different teams. We had very different training paths, 7-year neurosurgery residency and then a fellowship versus a very different neurology residency. We work closely because a lot of times a patient that needs neurology also needs neurosurgery and vice versa. So we're friends with each other, but we're very different. But I've noticed over the years, there's a habit or a culture among NICU nurses to just call both of us neuro. Whereas like in other parts of the hospital, like I'm neurosurge and they're neurology, or I'm neurosurge and they're neuro. But I've definitely gotten some pages over the years where it's like looking for neurology, but they said neuro and the page operator sent them to neurosurge. Does that make sense? So I would encourage you to sort of realize we're different. Like I'm as similar to a neurologist as a general surgeon is to an internist, right? Like a general surgeon and internist both take care of belly problems, but if your appendix was about to burst, your internist doesn't know how to take your appendix out. Similarly, though, the general surgeon's probably not your best bet for like working through a complex like medical regimen for, whatever belly problem you may have. Like they might work on the same area, but they have very, very different skill sets. And then when it comes to these germinal matrix hemorrhage patients, I think it can sometimes not be recognized that a lot of what we're doing is behind the scenes. The methodical charts we have kept for every patient we're following and that we're updating every time an ultrasound happens. Like we might breeze in quickly, feel the fontanelle and say, this one's good. They just need another ultrasound in a week. I hope you realize that's not the extent of our assessment. And really, it's just the modern way of taking care of them is to be driven by the ultrasound findings more than by waiting for symptoms. And then lastly, I'm just really proud to be at CHOC. We have low shunt infection rates, as I think I mentioned. We have a really robust multidisciplinary spina bifida clinic, which I didn't get a chance to really touch on too much today. But these kids with spina bifida get incredibly complete and thorough evaluations in that clinic twice a year or more throughout their whole childhood into adulthood. That clinic involves PM&R, orthopedic surgery, social work, pediatrics, neurosurgery, urology, GI. Like an orthotist. I mean, there is an incredible meeting of the minds that happens every other Thursday, just to make sure that these kids get the kind of 360 care they need. And then, I got to give Matt a big shout out to Dr. Mahonen. The reason I'm here is frankly because he recruited me, knowing that we both do similar shunt and hydrocephalus research. And the lab he's created is like spectacular. There's maybe a half dozen labs in the country that are as focused and robust in working on new strategies to tackle pediatric hydrocephalus and make better shunts. So it's a really special lab that he's built. And I don't know how much awareness there is of that on the clinical side, but I'm doing all sorts of work on germinal matrix mouse models. I got all these little mice running around with post-hemorrhagic hydrocephalus that I'm trying to, figure out better pharmacologic therapies to prevent that. So we're doing a lot behind the scenes to try to, push forward the way we care for these patients.
Where were you keeping the mice, Dr. Hanak?
In the animal facility where the mice live. I don't know.
Thank
It's
you.
like the clinics, the old research building is that the outpatient clinics building that a lot of the clinics have now moved to the new Southwest Tower. It's like if you were to go on the hospital side, it's on the hospital side. You can go to like that parking. You can walk around to the parking garage, and there's that clinics building there. I don't know how to describe it. I know to get there, but I don't know how to describe it. Behind that clinics building, there's an old kind of laboratory suite building. It's like where Raymond Wang's metabolics lab is, and other labs are. It's not a spot you would have necessarily passed by in your clinical care, but we're in the process of moving our lab space over to the new Southwest Tower lab space, actually in the coming days and weeks. But the animal facility is going to remain housed in that little tucked away building back there. They don't tend to like to advertise the existence of animal facilities anywhere, right? Because of PETA and protest and all that. But yeah, Jock has one, and they do a nice job. We have good veterinary staff. Sorry, Emily, I didn't mean to cut so much into your time.
Thank you so much, Dr. Hanak. I know you have to run, so no stress if you need to sign off, but I will turn it over now to
I'm going to
Dr.
see one
Garavatti.
patient, and then I got to hop a flight to Memphis for the big pediatric neurosurgery meeting starting tomorrow.
Awesome. Thank you so much. I appreciate your time.
Thank you. Have a good one, guys.
So we have Dr. Garavatti and then also Dr. Inder here, and they have graciously given us their time to talk about MRIs and what that means for us and what we should look for in our NICU population. So I'll turn it over and stop speaking so you can make the most of your time.
I am trying to figure out how to get into a present mode, but it doesn't look like my screens want to cooperate. So we're going to do it. Nope, not that. Hold on.
Should be under the bottom green share.
Yeah, it's the problem is the screen it's sharing. Well, I mean, I can try it from here and see what happens. I have a funny screen set up, so. And also, we do screen 2. Okay, now can you all see the screen?
Yes, we can.
Great. Okay, sorry, I just saw the thumbs up. So we're going to be talking about MRIs, and this is a PowerPoint created by Terry Ender, but it's going to be presented by myself. If I have not gotten the chance to meet you, I'm Emily. I'm one of the newer neonatal neurologists, and usually I'm covering NICU service when Simon Kyle is not on. And my areas of interest are neonatal neurology, but also neurodevelopment. All of our children, I think, that graduate from the NICU can benefit from following within neurodevelopment and getting close follow-up in those first few years because they're all very high risk for developmental impairments. First off, I wanted to just kind of acknowledge the impact the environment we have has on impacting babies' long-term neurodevelopmental outcomes. So there's a lot to do with their reason or health cause that they're in the NICU for, but also recognizing that there's a lot of things in the environment like the noise, the room type they're in, the speech that they're exposed to, how often family can be there that also have a significant impact on them. And specifically, one of the areas that I've been really interested in is stress. Um, and stress has been something I think that's been hard to quantify and measure in our babies. And we think that that's one of the big contributors to outcome. But again, it's hard to measure stress in a baby. And so we have a study that is active and live right now that we really need your help on. We're trying to define stress that babies experience while in the NICU with different medical procedures. And there was an email that came out, but there's a QR code here on the bottom. You guys can scan it and it would open up the survey. It takes about 10 to 15 minutes to complete. And like I said, it just lists all the different exposures that these babies have while they're in the NICU, and asking you to rate how stressful they are for them. And this is going to be used to develop a tool that we can do to try and measure stress. And so we really rely on your expertise as the bedside nurse spending the most time with these children to be able to help us like determine how stressful each thing is. So if you guys have not already done so, we'd very much appreciate you taking the time to do this survey. We are about at halfway at our goal. We were really hoping to get a large cohort of nurses. Right now we're at less of like right at 100, slightly under, and we are really hoping to get closer to 200 so we can be really well powered. So very much appreciate everyone who's already done it, and if you have not done it, please do so. Um, so the MRIs, we're going to be talking about how to MRI an infant, what the images are, what they mean, and some of the newer things that they are doing using MRI. This is a baby that's all bundled up for their MRI. So we're talking about how to do MRI without sedation. So about an hour prior to the scan, the infant's supposed to be wrapped in a blanket, which is their inner layer, and then they get the vacuum beam bags, which is their outer layer, given some head covering and some swimmer's earplugs and earmuffs for the noise dampening. And then the infant should be switched onto MRI compatible EKG leads and O2 monitors, and all the tubing, making sure it's MRI compatible. And then you want to tighten the vacuum bag right prior to transfer. Oops, sorry, that popped ahead. Right prior to transfer, and you want to make sure that you have the time ready so that when you're bringing the infant down, it's right at the time that they should be getting scanned. And that's all to try and minimize the chance of waking the child when you get them into the MRI. So the trying to feed them and swaddle them works pretty well for short scans, and it can be less successful if you have longer scan times, or the older the child gets, the less reliable this method is. But most of our babies that are in the NICU should work. It usually works for under 3 months of age. And but it also depends on making sure that everyone's communicating and timing everything appropriately. I don't know, Doctor, and if you have other input from your experiences with this, because I think these are your pictures. Nope. Okay.
Yeah, I mean, what I would say, and I think all of our team are aware, is that this is currently not our current model of care. Currently, at the moment, we take our babies down and the MRI techs check them over and wrap them, and we don't prep them fully in the unit. This is something that Beverly and I had been working on as our next, perhaps, area of opportunity for our nurses to take control of this to shorten the amount of time that the baby's off the unit and get them all ready in the unit. And we've looked at buying one of the MRI compatible monitoring devices. So this is something that we hope to move towards because it certainly is much more efficient, effective for the baby, and has good time utilization both for the nursing staff and for the MRI suite. But it's a work in progress.
So the motion degradation and scan success. So when you scanning infants using the feed and swallow, noise reduction is really important. The using earplugs that go in the ears and then also covering them with noise attenuators tries to really reduce the level of noise that they're exposed to and minimizes the chances that they're going to wake up during the scan. And then additional techniques include using or modifying the actual scanning machine, trying to minimize like the noise that comes from that. Um, and there are certain sequences that can be louder, and so doing those towards the end of the study can be really helpful. And also repeating some of the ones that are like have some motion degradation. So if a child wakes up and they move a little bit, that could impact this quality of the image. And so repeating some of those until they become a more diagnostic quality can be helpful. And then in more rare situations when there's a lot of movement, I don't think that we are set up to do this right now, but in some places, having consultation with the ordering clinician so they could come up with a plan for sedation can help minimize some of the unproductive time down in the scanner. But I think all of our children, if they fail their scan, I think they come back up rather than having that window to be able to try and regroup and reattempt the scan. So the fundamental principles for maintaining the high signal to noise ratio include avoiding too small a field of view, too thin of sections, and too small of voxels when possible. So the signal is the image that we acquire, and the noise is the extra like degradation that can happen from either movement or related to the equipment. And so you want to get good quality images that have a low amount of noise or degradation to them. Sometimes that means using thicker selections and larger voxels so the images aren't, it's like if you do the pixels on like a picture, bigger pixels gives you like a little bit lower quality image, but it can be done in a quicker time versus doing really smaller voxels can help with the quality of the images. And again, we're trying to produce good quality images and minimizing the time that this scan takes, whether that if the infant's sedated or if we're using feed and swallow and we have that limited window. But overall, the most important thing is trying to get a good quality image that can answer our clinical questions. And very exciting, there are newer MRI machines that are actually specifically designed for the NICU population. I'm sorry, that moved. Specifically designed for the NICU population. So you can see this is one here. This is Aspects Imaging. They created an MRI machine that is small, that is meant to be in unit in the NICU. It is its own isolated thing. So MRI machines, I'm not sure if everyone knows, actually the room that they're in have a lot of special equipment in the way that the room is designed and built that make it that you can't put an MRI machine just in any room. And so essentially what they did is they took a lot of that technology and put it into the machine itself. So this machine can be housed in any NICU unit. And it is specified for most of the patients that are in the NICU. They can scan between 1 kilogram to 4.4 kilograms and up to like a 38 centimeter head circumference. So the vast majority of children would be able to be scanned using one of these. And I believe Dr. Inder has been working to try and get one of these in our unit. So we don't have one coming yet, but hopefully in the future, we would be able to get something like this. It would make it easier, minimize the transportation time for these infants, and then also their time off of the unit. I don't know, Doctor, and if you had anything you wanted to add before I move.
No, any nursing support at any time or anybody support at any time of our need and how challenging it is and how some of our babies like babies on CPAP and I mean the leadership seems to have difficulty understanding why we can't just take every baby down to the scanner and I tell them that when they're on ventilators and nitric and even on CPAP that we can't get them down, then this really limits the importance of us getting this important information.
And then,
So tell them the babies matter.
and these are actually some pictures of images that came off of them. If you're not familiar with MRIs, which I know that we'll be talking a little bit about them more. This one's a T1, this is a T2, and these image quality, I'd say, are pretty good looking. That you wouldn't say that these are like necessarily inferior to the image we would get if you sent the baby down to the scanner we have in the hospital. So it's quite impressive technology and very exciting, hopefully in our future. So I was going to talk a little bit about the utility of an MRI. It's very good at helping us evaluate the brain structure. We can look at the development and maturation of the brain tissue itself, looking at the connectivity of the brain, and also looking if there's been any malformations in the brain, and also looking at injury, including hypoxic ischemic injury, hemorrhage, metabolic injury, or injury related to prematurity. So these are some of the things that the MRI can be really good at looking at. We have different sequences within an MRI. So the MRI is the entire scan, and within that, there are different image types that they acquire. There's the T1 and T2, and then diffusion imaging, and then susceptibility weighted imaging, and then spectroscopy. And we'll go through what each of these ones are. So starting with our T1 weighted images, these is a really good one for looking at structure. You can see for a T1, each image has a slightly different appearance to the brain. So in T1's CSF, where the fluid-filled spaces are dark. So in Dr. Hanak's lecture, he was showing us like, the ventricles getting really large. And here, that's all where the CSF is. And so you can see it's dark in this one. And then it's harder to appreciate on a baby image, but you think that out here is what we call gray matter. That's all of the thinking power cells in the brain, kind of nicely folded on the outskirts. It still looks gray. And then in babies, what's considered white matter will appear dark because they're not well myelinated. And the myelin is what makes white matter white, but you can see there's the beginning of their myelination. And if we look at this next one there, this is kind of comparing the two. So T1s are really good at looking, like I said, the macromolecules, like the lipids and proteins. That's a big component of what myelin is. There's a lot of fat, and you can see that babies are best myelinated right here in their posterior limbs of the internal capsule. And so you can see that myelin is going to appear brighter on the T1, and also I just realized also I've been using my mouse and I don't think it's on the screen that you guys can see. If I do it up here, can you guys see my mouse? No? I might not have a mouse function. Oh, wait, hold on.
Ask Dr. Hanak. He knows where the mouse is.
Can you guys see it now? Yeah, okay, great, perfect. So apologize for that. I hope I didn't miss anything significant. So we are saying T1s are good at looking at myelin. The posterior limbs and the internal capsule are back here, and these are different images. Day 1, day 2, day 9, and day 31. And the top image we know is our T1 because the CSF, or where the fluid-filled spaces, are all dark black. And below, that's comparing to a T2 where fluid-filled spaces will appear bright white. And you can see, as I was talking about earlier, the cortex out here, this thin like little ribbon along all the lumps and bumps. That's where we're seeing all the thinking power cells live. It appears a little bit lighter on the T1 as compared to the T2. And what you can see on these images also is that as babies get older, those myelin becomes a little bit more apparent. And if we go to the next one, we'll kind of talk a little bit more about T2. Advancing, there we go. So this one on the outside, these are T1s again, and these middle images are going to be our T2 images. And what again we can see is the fluid-filled spaces are dark on T1 and bright on T2. And you can see that the tissue itself appears different. The coloring and like appearance of the tissue varies between the two of them. And as we kind of mentioned, the T1 is really good for looking at the like lipids, proteins, larger macromolecules. And our T2 is much better at picking up edema and swelling in the brain, like if there's extra fluid. You can see there's not as clear delineation in some of the structures on our T2s as compared to our T1. And I realized as I've been talking, has everyone gotten the basic structures of the brain before, or should we quickly review that?
I think a quick review would be great.
Okay, great. So this one is one of our higher up ones, so we can start up here. So this is kind of the top of the brain. This is like right underneath the skull. At the top, we can see that there's two hemispheres. These are called the cerebral hemispheres. You got a right and a left, and then out here, the little squiggles and bumps, those were all the folds in the brain, and that's where the cerebral cortex is. Like I said, all the thinking power cells, and that is connected by a bunch of fibers, wires, cables that make up the white matter. So that's the tissue that travels in between. Um, and this image is, you can see these are normal fluid-filled spaces in the brain, the bright white here. And those are called ventricles, and that's where all the CSF is. And then these dark gray structures right here in the middle of the brain, those are the deep gray nuclei. I like to think of them as like a relay station in the brain. There's a lot of important information that travels through them, and then so like the fibers travel up from the body in our spinal cord, and then go into the brain stem, and then go up into these deep gray nuclei before they make connections with the various parts of the brain. So it's an important relay station that almost all sensory processing information make a stop off here before they go out to the cortex. So very important vital structures. It's also kind of on the underside of these is where a lot of the homeostatic processing happens. So regulation of heart rate and breathing and temperature regulation, um, and more autonomic responses are generated from these deeper structures in the brain. And you can see out here, again, this is where our white matter is, those thinking cables. And again, babies aren't well myelinated, so it appears still kind of very dark on our T1. This one is a further down, well, here, if we go this one, where I'm at right now, that's where if you're at the deep gray nuclei, and we go down, we can see that this is the brain stem, and you can still see the two hemispheres. The up here is called the frontal lobes. That's like higher thinking level processing information. You have your temporal lobes, which are down here on the side. Right here's the beginning, kind of where the temporal lobes start off. I should have thrown in an extra picture on this. And so temporal lobes do a lot of processing of auditory information. And then as you go further up, there you have your motor strip and your sensory strip that's all processed up here. And then the posterior regions of the brain back here are the occipital lobes, and that processes visual information. And then our bottom part of the brain down here is called the cerebellum. Some people call it like mini brain. It is an area that does a lot of refinement of movements, timing of movements, and coordination. But we also know that it is important for emotional processing and emotional learning, especially like sequence learning. And then, like I said, we have our brainstem that goes down into our spinal cord. All good on that? Okay. Next time I'll try to include another picture that actually breaks them down for you. So as we mentioned, T2 detects edema. So you can see here, when we look at that outer strip of that cerebral cortex, you can see it starts to fade, and it becomes hard to kind of see that difference between the cortex and the white matter. And that's because there's a lot of edema in here and swelling, and we actually lose completely not just the shapes of those lump and bumps, but we also don't see any spaces between them because the tissue is so swollen. It's kind of compressing all of that. So T2 is really good for looking at extra fluid or edema that can happen after injuries. Oh, I was pointing at the wrong screen again. I apologize. Here. is what I was talking about. You can see that we lose that cerebral cortex. It's really hard to distinguish. You can see it a little bit more up here. And as we go further back, it becomes harder to distinguish the difference between the gray matter and your white matter. And then you also lose appreciation of where the sulci are. And to the point you get back here and the brain looks almost smooth, and that's because of swelling. This is a good slide that shows some of the changes in the brain over time. So as I mentioned, MRIs are good for looking at development or maturation. And so what you can see here in these images is on the top row, we have our T1 images. Again, CSF is dark and our myelin or white matter is white. And then in our T2 imaging, our CSF is bright white. So you can see T1 on the top, T2 at the bottom. If we look all the way on the far end, what you can see is that these are the preterm babies, is about 31 weeks. You can see the general structure of the brain. There's two hemispheres. But if you look at the outside, that's not very well lumped and bumped. It's still quite smooth. And that's because the brain hasn't finished folding. So this is just a natural way that the brain would appear at this stage. And so we tell by looking at this and knowing the child's age that this is a normal appearing brain, whereas the same appearance in an older child would be considered very abnormal because our brain should not have smoothness to that. We want it folded. And the reason we want it folded is because that increases surface area, meaning that we have more of those thinking power cells in there. And you can see here is at 1 month. You can see again, we're well folded at this point. And these bright white streaks, these are the posterior limbs of the internal capsule that have the myelin. And myelin are the protective coating around our nerves that allows for our nerves to transmit signals better. And also you can see these are the beginning of some optic radiations that are traveling back towards our occipital lobes. And our occipital lobes, as I mentioned earlier, process visual information. So in babies, these are one of the earliest myelin tracts, or sorry, nerve fiber tracts that get myelinated. And that's because visual information, that's what babies are doing constantly, is trying to process and understand and look at the world around them. And as we continue to go on, you can see that they continue to myelinate their brain. By 4 months, you can start to see that we have myelin kind of extending to the frontal lobes. You can start to see that the corpus callosum, the connection fibers right here that connect the two hemispheres together, is also beginning to myelinate. And then by 8 months, much more apparent. You can see a lot more myelin. You can also see as we get closer out here, if you were to look, this white matter is starting to have more of that white appearance to it. And as I was mentioning earlier, in babies, it's very dark because there's not a lot of myelin. So if you look between our 1 month and 8 months, you can start to see the beginning of myelination, which we believe myelination is completed by 2 years. So this is a 3-year-old child, should be fully myelinated. And you can see now all that white matter that travels all the way out to the cortex. Front, back, completely myelinated at this stage, as compared to our adult brain. You can see that there's changes in head shape over time, but the overall, like the structure of the brain doesn't have a significantly different appearance between these two. And you can also see that those differences can also be appreciated on a T2. Again, the T2, the white matter appears darker. It's kind of inverse because what would be gray matter out here is lighter, and then white matter is darker than it. So it's a little bit more confusing using those terms just based on the images, the way it appears. But you can see, again, that myelination makes it look darker on a T2. All right, anyone have any questions? Keep going. So we talked a lot about structures of the brain that we can kind of appreciate on different images. So the next set of images we're talking about are ones that are good at picking up blood. So these are susceptibility weighted images. And what you can see is that blood, this one is kind of explaining the different time periods for blood. So the blood initially in the first 3 days is just going to be deoxyhemoglobin, and it appears low on T2, meaning dark on T2. an ISO on T1, meaning that it is not a significant change. It's kind of in the middle level. Whereas as the blood undergoes changes and becomes like methylmyoglobulin, you can see it becomes bright on T1. This is usually between days 3 and 5. And then in more chronic bleeds, it is again dark on the T2. This one is still an earlier bleed, somewhere between that 3 to 7 days. You can see on our, these ones are T2 up here because the CSF is bright white, and you can see this dark black. That's blood. So when they say low signal, it means that it's very dark. And then if you look our T1s, again, you can tell because the CSF is dark appearing in there, but then we have this bright white fluid in the ventricles. So bright on T1, we know that that one's blood, and this is a image of germinal matrix hemorrhage. And you can see this brain's a little bit smooth, so we know that this is going to be younger baby under term age based on how smooth their brain is. And so this is one of the most common bleeds that those children will have, and one of the most common injuries. So our susceptibility weighted images labeled on the MRI as SWI, and it allows us to detect blood. This one at the bottom, the pictures, you can see this is a T2. You can kind of see that there's a dark spot here in the cerebellum, a little bit difficult to appreciate. And then when you look at our T1, you can see kind of bright. But when you compare it to our susceptibility weighted imaging, it becomes much more apparent, and it kind of makes that pop out. So it makes it easier for us to see if, whereas if you didn't have that image, it would be a little bit easier to miss that. And then the next imaging type we're going to talk about is right here, our ADC. This is the type of diffusion imaging. And as you can see, it is not good at picking up blood. Hard to see that little hemorrhage on this sequence. But it has other uses. So there are a few different images that we get using diffusion imaging. And these are their different appearances, and we're going to kind of talk about each of them. And I think a lot of this is talking about kind of the science and mechanics behind it. So the diffusion imaging, it essentially looks at two different time points. They send like a pulse of not radiation, like magnetic pulse through a vector, and then they that will excite little molecules and they'll move, and then it does it from a different direction and again sends another pulse, and they're looking at the molecules that moved versus didn't move. And it can be helpful because fluid will move a lot more easily, those molecules within fluid in the brain. And so they will have a big difference after injury. You can see there's more fluid in the brain, and you can pick that up using the diffusion weighted injury. So it's good for early detection of injury. But using that same technology, depending on how you're applying that pulse and kind of the direction of where you're measuring it, it can also be used to look at myelination and cortical development. And then using, again, that same technology, depending on the orientation of it, it can be useful for following the different white matter tracks that are in the brain and what that translates into. So these are just some of the considerations. So next we'll have some of the images, but you want to try and optimize how you're getting those images, and that's what I'm saying, how many directions you're doing it in, and also trying to minimize any movement because you're trying to look at the movement of the molecules by emitting like this pulse through them. So if you also have movement artifact from the infant moving, that will interrupt your ability to acquire these images. So you really need not to be moving for these images for them to be helpful. And these are diffuser tensor imaging. These ones, you can see this is the one when we said good at looking at the different fiber tracks. You can see these bright colored ones kind of orient you to the direction that things are traveling in. I think the next few images are going to be a little bit better because I broke them each down. So when I initially was telling you about the injury that you can appear, can anyone tell me what's abnormal in this picture? Is it in here in the basal ganglia, deep gray nuclei? Maybe this bright white back here. Yeah, I see some head shaking. Great. Um, so this is imaging. So when we say diffusion, there's two different images that you get from it. This one's labeled DWI. Another label that you might see for it is SB1000. And in those images, when you see bright white, that's the abnormal part. And you can see the rest of the tissue. I mean, there's a little bit of differentiation, but overall, these are shades of gray, but this clearly bright white stands out. It has a paired image that goes with it called an ADC. So when we look at diffusion imaging, you should always have like a DWI or SB1000 and an ADC. And what you're looking for is on this sequence, it appears really bright. And then on the ADC, it will appear very dark. And when the two of them line up, you can feel really confident that what you're seeing is an abnormality and not necessarily just what we call like artifact or abnormal or like signal that comes just from the image itself, but rather this is signal coming from injury within the brain. And then it's comparing it with the T2 that we would also be acquiring at that same time period. And harder to appreciate in like injury on here. If you just look at this one, it doesn't necessarily stand out, but now we know that there's injury in the back. So again, if we were to look a little bit more closely, you actually can see that there's that swelling there where we're losing that cortical ribbon back here. It becomes harder to appreciate the curvature of the brain. The gray-white differentiation becomes harder to appreciate. And so you can see that there is actually swelling back here. But you can see on our diffusion imaging, it really makes it pop out that there's injury in that area. So although you can see it on T2, our diffusion imaging helps us be a little bit more sensitive at picking that up. And one of the things that we'll talk about a little bit more later in the lecture is that, the time point of when we image children is really important. So this was an injury, and it tells us here that this was obtained at about 12 hours of life. This was a term baby that had APGARs of 5, 5, and 5. And this is what we would call like a hypoxic injury. And importantly, at 5 months, you no longer see that same like amount of swelling back there. And it's because we would expect the swelling to go down after the injury is like resolved. And so the time period of where you get your imaging is really important for helping you see the injury. But there are still some limitations to it. This is once again looking at our T2, our ADC, and our DWI. So each like 3 images are kind of paired all together. I think this one down here is for me the easiest one to like immediately pop out that this one looks a little too bright in here. And you can see it looks a little bit dark on here. And this one's a little bit grayed out. And so this looks like pretty bad injury. But the question is what level should you be looking at and how do you determine if there is injury between, bright, dark? And as I was saying, time period really makes a big difference for the sensitivity of these images. And this is a chart looking at what we would see on imaging based upon the time period. And so on the bottom, we have days out from birth. And then up here, we have a ratio comparing the image intensity. And I think this one's, oh yeah, there's animation here. Great. So what you can see here is our red line. Making sure I'm looking at this correctly. Our red line is going to be children who did not get cooling. And what you can see here is you can see the signs of injury right here early on. We can see usually around day 2, between day 2, 3, before day 4 is kind of really our peak time period where it's the maximal difference that we can see. But if you look up here by day 6, we're starting to see that's actually almost completely returned back to this baseline normal value. So we're starting to lose that signal intensity that we saw on diffusion at about 6 days out from injury. We found by imaging a lot of babies over time that cooling does slightly shift that window of when we can see these changes. And so they might have changes a little bit further out. But in general, we like to get children down here. We want to capture them when they're going to have that maximal difference that we can see on their MRI. And so really, we aim for day 4 because day 4, they're off their cooling and trying to get them down for imaging and absolutely trying to get that image before day 6 because by day 6, that image quality or signal intensity is starting to go down. And we call this process pseudo-normalization. Pseudo meaning kind of fake, normalization meaning it appears normal, and so you're losing that acute signal intensity from the initial injury, and so it will give you like a falsely reassuring appearing diffusion imaging, and this is before you would start to see some of the changes that might appear downstream from this injury on other sequences. So when we look at our evolution of injury and kind of our timing, you can see we have our different time periods over here. That, and if we were to image in the first 24 hours, just looking at our conventional imaging, we wouldn't see anything. But on our diffusion, we might see some mild changes. In the first 24 to 72 hours, again, conventional imaging might not see anything, but diffusion, you can start to see decreased ADC. And by day 4 to 7, we're seeing the decreased ADC, our diffusion imaging, and then our possibly some fractional anisotropy, which we will talk a little more about, also have some changes. And by day 7 to 14, we think that that pseudonormalizations come in, and so now we see that normal appearance here, and we're starting to maybe see some of the T1, T2 changes beginning to evolve. And then if we go down to 14 days, you can actually see the downstream effects of that injury with atrophy, meaning that the tissues that was injured, the ones that could not survive that injury, they actually die off. And so atrophy means that that tissue is going to start shrinking because the cells will start getting reabsorbed. And you maybe will pick up some of these other differences during that time period. I'm not moving forward. So this is a image from a term infant that presented with right upper extremity and lower extremity shaking in the first 36 hours of life. Anyone want to take a stab where we see abnormality? Up here in the front?
Bottom
in the
right.
back? You're right, yes, correct. Yeah, you can see back here in the right, when we look at our diffusion weighted, we see this bright white here. We look at our ADC, we see it's dark. And so we can see that there's significant injury here in like the occipital lobe. It appears on your right, super confusing MRIs. It's actually patient's left side of the body because we flipped everything when we put them in the scanner. And so that's our diffusion imaging. When we look here at our T2, again, really good at looking at edema or like that swelling because there's extra fluid in that area. Again, it looks kind of hazy in that area, not as good as differentiation. And if we look at our T1, we can also still appreciate like the gyral pattern is lost in that area. Just doesn't have the folds and lumps and bumps that we would expect. And then if you look at our susceptibility weighted imaging, which is really good for looking for hemorrhage, they found that there's actually a little bit of area where there's some extra bleeding in it that was really hard to appreciate on some of the other images. But because we looked at this one, we know that there's also a little bit of bleeding, which is not uncommon to have bleeding after you've had significant like hypoxic ischemic injury. They call it like hemorrhagic transformation from an infarct, meaning that the tissue suffered this injury and then you have bleeding into that because it breaks down kind of that barrier that allows the blood vessels to stay nice and plumped and they are more prone to rupture. And so these top images were day 3, so kind of that peak, right within that peak window, maximal image. So if we go out to day 9, you can see this process of pseudonormalization has kicked in. If you were to have gotten, this is your first image, say this child was, critically ill and on an oscillator for some reason and could not go down to imaging, and you got it on your first image on day 9, you would have missed all of this tissue head injury just based off of looking at this, because really you're only seeing what's left and some of the white matter tracks still kind of appearing on this image. This is, like I said, what we call that pseudo-normalization, where it appears normal, but it's more the time period you got the image in. And again, when you look at our T2, you can see, yes, there's some signs of injury there, but it's much less pronounced than on the initial imaging at day 3.
Thank you. Is she frozen?
I was gonna ask the same thing.
Dr. Garavatti, I think we lost you. Oh, I'm gonna pause recording. There she is. Hi. Oh, you muted. I think you're still muted.
Sorry.
Oh, good. Thank you.
When it kicked me out, it apparently remuted me. So I said, I realized I was frozen and I got the time period, but I don't know at what point I became frozen. What was the last thing you guys heard?
The great question. Do you have your slides again?
Yeah. I'm still on, I think, the same slide. I just don't know at what point it froze for you all.
Just the change over time, really, from,
Oh, was I at the end then?
I think,
Like I already, okay, great. I looked back at my screen, it was completely frozen. So yeah, so the time period that we get our images can really help us determine the extent of that injury. Anyone have questions on it? Nope. Okay. So we talked about the diffusion imaging being really good at looking for hypoxic ischemic injury, meaning there wasn't enough oxygen to the tissue, which is what we are thinking about with HIE. There are different patterns that we can see for children who come in with a concern for encephalopathy. They get put on their cooling protocol, and then we don't know what like injury they have until we get that MRI. And so this one shows some of the most common patterns of injury that we can find when we do their post cooling MRI. So first pattern, which is thought to be one of the most common ones, is our central basal ganglia thalamus one. So you can see is our basal ganglia in here, which I don't think I explained. I think I called them all deep gray nuclei earlier for you. So your basal ganglia are kind of these structures up here, and then your thalamus are these nice plump balls back here. So we can see is that the basal ganglia has some injury. The thalamus looks like they have a little bit of injury. Here, what we call hippocampi, which are regions that are important for memory formation, also appear injured, but all of this injury is, like I said, deep in the brain, kind of in these central structures. And we can see that that injury extends up to those motor strip that I kind of briefly pointed out earlier. This is where all of the motor movement in the body is controlled. This is called the motor strip. So it has everything from your foot and your leg in here, through your face, through your shoulders, down to your hands, kind of along this strip. And so this is one pattern of injury that you can see. The other one that is still decently common. I think they think up to about 15% is what we call peripheral or watershed. Briefly, there's different blood supply that comes into the brain. You have some that come in the front, in the back, and then on the sides, different blood vessels. Watershed is the area between the blood vessels. So we can see this is between what would be our ACA and then our MCA blood vessel. We can see these diffusion injury right in here. And then our PCA comes in the back, and again, the M stays on the side, and right in between those two, we're seeing that injury here. So this is what we would call like watershed injury, which is that the perfusion went down for some time period, and so the areas that were right along the blood vessels were still able to get some energy, but it was not enough to get to the more distal areas at the end of those blood vessels. So those more distal areas didn't get enough oxygen. The next one is punctate white matter injury, which you can see are these bright little white spots. They're kind of small, individual little dots that can happen in the white matter. And then D is the global injury, which is you look and the entire brain looks like that it has injury. This one actually can be really hard to detect if you don't know what you're looking for and you don't have the clinical information. I've seen these get read as normal because when you look, it all looks kind of bright. But the giveaway is that you can see a difference here where the cerebellum appears much darker and then the cerebrum above it appears much brighter. And so although you don't see any bright white glaring out like you do in some of the other pictures, it's because the entire brain is injured. And so all of it is brighter than it should be. And so they call this like the inverse cerebellum sign, which lets you know everything above the cerebellum has significant injury. And the next one is brainstem or deep gray nuclear, which, as we pointed out earlier, this is our brainstem. We can see it has bright white, so signs of injury there. And then we see some in our deep gray nuclei here also have some injury. And then I am inclined to say this is probably artifact back here, which we hadn't talked about yet, but it appears bright white. But if you look at it, it's right along the skull base, and this is a common appearance for what we call like artifact, which sometimes it's like what they call like T2 shine through, meaning that we're seeing imaging artifact coming through and not necessarily injury to the brain tissue. Next one, cerebellar injury. And you can see that's back here. It's hard without the comparison image. If you look down here at this corner under D, global injury, you look what the cerebellum looks like, and then you look back at the cerebellum up here, you can see this one's a little bit brighter and had injury to it as well. The next ones are perinatal arterial ischemic stroke, which means that there was a blood vessel itself that had gotten blocked and lack of oxygen to everything that downstream from that. So you can see this one, you can kind of pick it out because it ends up being a chunk of tissue that's all kind of connected in the right distribution for a particular blood vessel. So you can see the PCA still comes in here. And this is kind of our MCA distribution. And then H is our bucket of other, which is sometimes we have babies and we do cooling, and then afterwards they don't have one of these classic appearance of injury, and they can have a variety of different types of lesions that cause them to be encephalopathic at birth and get put on the cooling protocol. And if we were to look at this image right here, so we have our diffusion image, it's bright white right in here. And then this one is our T2 image, and there's dark black in here. Anyone know what that is? Blood. So remember we said that blood can appear really dark on T2 images, so that this is some sort of bleed that the baby had, and they have some tissue injury surrounding it. So that was diffusion imaging, kind of looking at signs of injury. But as we were talking about earlier, diffusion imaging can also be used to look at the direction of some of the connecting cables, fibers, and also look at the presence of myelination in it. So we have at the top here our diffusion imaging that we've kind of looked at before, where it's going to show you injury. So we don't see any injury on this one, but the fractional anisotropy is a type of diffusion imaging that looks specifically at myelin. So you can see the areas of the brain that have myelin in them very well on this sequence. And then also using that same diffusion technology, this one is a directionality map. So it's looking at the direction of the fibers, like nerve fibers. And if you look over in this corner, we have um, a little diagram for us. So you can see green is going to be going forward, backward, red is going side to side, and blue means that it's in the, what direction is that? X, Y, Z direction. So kind of going up, down. So you can see these, we have like our optic radiations look like they're traveling front to back. We have the fibers traveling out here to the frontal lobe. And here's where we have those posterior limb of the internal capsule carrying all those motor fiber tracks that are going up to that motor strip in the brain. So that's coming upwards. And then we can see here in our corpus callosum that connects the two hemispheres of the brain. It's red, it's going side to side. So this type of imaging, although it's beautiful, the beautiful colors actually do have different meanings to them and showing you the directions that the different fibers are traveling. So a lot of different types of information that we can gather from an MRI, all depending on which sequences that you're using and which technology you're using to do some of these calculations. Some of you might have started to see that DTI, diffusion tensor imaging, is sometimes an order that's being added on to our HIE population. So you'll sometimes see it as a separate order. It says DTI on it, and that's these colorful images. So we're getting them on some of our babies. And that information can be used to look more closely at the different fiber tracks and looking at that connectivity in the brain. So this one, although it's colored, the colors are not indicating direction. The colors are actually nerve bundles that are showing different connectivity in regions of the brain and kind of the nerve bundles that are all out there. So, but this image is generated from the going back if I can, Darren. So that type of image that I think is easier to actually see all those fiber tracks in is generated from an image like this, which you can reason your way through and you can see there's a lot of different colors, but it's really actually hard to see how much nerve fibers are in there. Whereas this one breaks it down and you can kind of see the density better of how many nerve fibers are in that area. And this I don't think we talk about it as much later, so I'll just briefly mention it now. This becomes really important when we think about maturation of the brain, but specifically also thinking about dysmaturation of the brain. And for our babies that are born incredibly premature, the connectivity is something that happens in the third trimester. And usually those babies are in utero and not exposed to different environmental stimuli because they're kind of in that warm little incubator that keeps everything pretty constant for them. Um, and when you are born premature, your brain's not done developing, but then they're also exposed to all of the different environmental stimuli that we kind of had on that first slide, light, sounds, painful procedures, voice. And these types of imaging has been really interesting comparing, looking at some of those developmental changes that can happen in maturation process based upon some early alteration in life exposures. All that to say, not clinically used right now, but has been used in research to look at some of these differences. The last type of imaging sequence we would call is MR spectroscopy. I don't know if I should call it sequence. It's actually its own type of MRI. It's a separate order. And spectroscopy looks at the breakdown of different metabolic products in the brain. Oh, are we over?
We're a little over time, but I'm still
Okay.
recording. So if anyone needs to sign off, that's great. But I can keep recording and we'll post this on our Teams page or on our SharePoint page.
So keep going for now.
Yeah, go for it.
Okay.
Thank
So these are all, it measures the different breakdown products or metabolites in the brain. And the next one, this is going to actually explain them. So the first little bump, so you see it generates this little line and these different peaks that you see are going to happen at certain measurements, and they correlate with the different metabolites. So based on how big the peak is, it tells you some information about how much of that metabolite's in there. The first little peak you can see is myoisotal. It's a glial marker. The second peak, we have them labeled differently, but if you actually look, the second one is choline. It's a membrane constitute. I don't know how I'm saying this right. Constituent. I said that right. Sorry. The third peak you have is creatinine. This is a measure of the cell energetics. The one down here, it's not so much a real bump peak, but you can see that there's this little bit of elevation in here. That's glutamate. And then you have your NAA, and it's a marker of neuronal axonal density and viability. And a big thing that is looked at on imaging is kind of your NAA to choline ratio. Um, and that helps you determine like level of injury. And then the other thing that's really important when we look at for possible injury is our lactate. So lactate is what's made when you don't have enough oxygen. It's going down like the anaerobic process and due to the lack of oxygen. So in normal states, you shouldn't have a lactate peak because your brain's using oxygen, so it doesn't have to flip to anaerobic respiration. But when the brain experiences a time period of not having enough oxygen, it will flip into this cellular process. And so lactate is generated from that, and you'll get this peak down here. And so it's used as a marker of failed oxidative phosphorylation, and it is also produced in astrocytes and shuttled to neurons to use as fuel. And we can use it as a marker of having had hypoxia, but also it can be seen in certain metabolic conditions. Um, how much, there's a lot of slides here, and I actually think I didn't time it well because I'm a little under halfway through. So how much do you actually want us to go through?
I think it would be good to come back, Emily, and maybe
Yeah.
Katie, we can have
Yeah.
another session on not just malformations, but I think the most important thing is how do these changes relate to outcomes and how do we talk to families about those? So maybe we put that on for another scheduled event because I think we have a lot of data related to the patterns of abnormality on the MRI and the expected outcomes. And I'm sure the nurses would really love to hear more about that and have a good discussion, and maybe I can tag team Emily on some of that.
Yeah, I think that would be a great idea. Thank you so much, Emily. This was really, really interesting and really helpful for us. So very
Yeah, thank you guys for having us. I appreciate that you guys want to learn how to look at imaging better.